This webinar contains audio descriptions for the blind and visually impaired.
All right, good morning, everyone. It's 11:03 now, so we're going to get started. Welcome. Thank you for coming to today's Local Educational Agency Medi-Cal Billing Option Program, or LEA BOP, webinar on how to start and participate in a billing consortium. So if you have any questions during today's webinar, please submit them into the chat. We have DHCS staff monitoring and noting the questions submitted via chat, and we will either respond during today's webinar or in writing after today. Just to note, we may ask you for your name and email address if we need to circle back with you. To access the chat, please click on the chat icon at the top of your Teams toolbar. A meeting chat window will open to the right where you can type and submit your questions. Also, live transcripts are available for the hearing impaired. To activate this feature, find the More icon in your Teams toolbar. Click Language and Speech, which will bring up another pop-up where you can click Show Live Captions. You'll be able to view the live captions in the bottom panel of this meeting. Please also remember to remain muted for the meeting. Again, questions will be fielded through the chat, and if we have time at the end to go over some live questions, we may request that you unmute yourself if further explanation or clarification is needed. However, for the time being, please be sure to mute yourself upon entry. And we're going to get started with just a few introductions. We have several DHCS staff on the call today, but today you will be hearing from the provider relations team. And team, feel free to wave when I get to your name. So on the call today, we have Sarah Bukowski, Lydia Outland, which is me, Ankita Singh, Lacey Alred, Trung Tran, Sherry Crandley, Leanna Perez, and Natanya Karat. And of course, we are very excited to welcome our guest speaker, Debbie Connor from Mendocino County Office of Education, who is willing to once again grace us with her expertise and experience as a lead consortium. So this workshop is part of DHCS's efforts to increase understanding about the LEA BOP and provide and improve program participation among LEAs. While not all do, some LEAs find the program to be administratively burdensome. There are a variety of strategies that LEAs can use to address that. Given the administrative requirements for participating in LEA BOP, today's workshop will cover one strategy for how LEAs can collaborate to share some of those administrative responsibilities. And the goals for today's workshop are for participants to understand the administrative responsibilities of LEA BOP, the benefits and considerations of joining a billing consortium, and the purpose of a billing consortium and requirements as a lead or member. Before we dig in, I wanted just to quickly clarify. Via registration, we received a few questions regarding the Children and Youth Behavioral Health Initiative, or CYBHI, consortium structure. Both CYBHI and LEA BOP have a consortia option. However, they are different structures for different programs. Today, we will only be discussing the consortia structure as it relates to LEA BOP. For any questions regarding CYBHI's consortium structure, please feel free to reach out to dhcs.sbs@dhcs.ca.gov. Here's our agenda for today. We begin with an introduction to LEA BOP and administrative requirements for program participation and the consortium requirements and structure. Then we are so lucky to have Debbie Connor from Mendocino COE joining us to provide real-world example of a consortium in practice, as well as reinvestment of funds for a consortium. This will be followed by some question and answers, some submitted via registration, and if time allows, a few dropped in the chat during our training today. And finally, we will close out today's session with some helpful resources that you can utilize. Presentation slides and recording will be posted to DHCS's website in the future, and participants will be notified via eBlast when they are available online. And we did send out a copy of the slides earlier this morning, so you should have a copy, but let us know if you're still in need of one. And on this side, we just wanted to add a quick description of terms or glossary of terms for today's webinar. These are just a few terms we will be throwing around during the training today, such as billing consortium, which is a group of LEAs coming together to share the administrative burden and bill under one NPI number. The lead billing consortium, or lead LEA, which is the lead LEA who has taken up the responsibilities for coordinating with all consortium members and hefting most of the administrative burden. There's the lead billing consortium coordinator, who is the individual chosen to coordinate program involvement and to be the point of contact between DHCS and consortium members. And then there is the consortium members, or member LEAs, which are LEAs that participate in a consortium but do not take on that lead role. And now for our first section, I would actually like to hand it over to Sherry. Thank you.
Lydia. Good morning, everyone. My name is Sherry Cranley, and I'm an analyst with the Provider Relations Unit. And we are going to start off our section by providing an overview of LEA BOP's administrative requirements. For many of you, this may be a bit of a refresher, but some key things to know about the LEA BOP are that one, it's an optional program to recoup some expenses for providing covered health services for students enrolled in Medi-Cal. And two, that LEA BOP is an ongoing funding source. LEA BOP is a billing and reimbursement program that generates funds for the costs your LEA incurs to deliver covered services. On this next slide here, we have a graphic showing a simplified overview of the payment cycle. Previous workshops have provided a much more detailed overview of this payment cycle and how the funding mechanisms and timing work for this program. But for today's training, we'll provide this simplified overview of the process from left to right. So first, the LEA delivers services through allowable practitioners employed or contracted with the LEA. Next, the LEA submits claims to Medi-Cal for covered services. Then the LEA receives interim reimbursements for those allowable services throughout the school year. After that, LEAs reconcile actual costs with those interim reimbursements through the cost report that is submitted 8 months after the end of the fiscal year. Then those actual costs are audited to verify that they are allowable expenditures. And finally, the process concludes with a final audited payment within 18 months. And these are a lot of steps with a lot of complexity, requiring administrative capacity and backbone support for LEAs to participate. For today's workshop, it's important to note that Billing Consortium, which we will describe shortly, can help LEAs with a lot of the payment cycle and processes. And here on this slide, we see a graphic representation of the administrative requirements for LEA BOP participation and how LEAs participate in the program as a single entity without being in a billing consortium. To set the stage for how billing consortia can be beneficial, we'll first review these administrative requirements and how LEAs participating as a single entity meet these requirements. So each LEA provider has a direct relationship with DHCS, represented by the dotted lines between each LEA and DHCS. Each LEA is responsible for all of the administrative requirements listed in the boxes below. As a refresher, we will briefly walk through those administrative requirements. So first, the compliance documents, such as the Provider Participation Agreement, or PPA, which is the overarching agreement between the LEA and DHCS that must be put into place when enrolling in the program. The annual report, or AR, which provides DHCS with the most up-to-date contact information and program participation changes. And the data use agreement, or the DUA, which outlines the responsibilities and requirements of data sharing between DHCS and the LEA and a vendor if applicable. And then second, the Random Moment Time Survey, or RMTS. This is a statistically valid time study mechanism that California uses to determine the amount of time spent on activities throughout a participant's workday. The administrative component for RMTS is ensuring all eligible practitioners are on the Time Study Participant, or TSP, list, as well as ensuring practitioners are responding to the moments that they receive. And we have conducted a previous workshop about this subject, and those slides are posted online. And as well, we will also be dropping a link in the chat for you as well for that past workshop. Third, there are day-to-day claiming and service documentations required, including submitting interim claims for treatments and assessments, ensuring that services provided to students are thoroughly documented, ensuring that practitioners are appropriately licensed and/or credentialed, and reviewing the electronic health record systems or whatever system is used for documentation for practitioner compliance. And lastly, but not least, the cost report or cost and reimbursement comparison schedule, also known as the CRCS. And this is the annual cost report that participating LEAs are required to submit that certifies the costs of providing LEA BOP covered services to students. And so the main takeaway from this information is that these are some of the administrative responsibilities that can act as barriers for some LEAs to participate in the program. These can also be mitigated by participating in LEA BOP through a consortium. And to start that discussion, I would like to now pass it along to Lacey.
Thank you, Sherry. Hi, everyone. My name is Lacey Allred. I'm also an analyst with the Provider Relations Unit. And now we're going to talk about consortium requirements and structure. So in this graphic, you will see how the member LEAs interact with the lead LEA, and that the lead LEA is the one turning in the paperwork with DHCS in a billing consortium. In the previous slide, we mentioned the administrative requirements, the details of which we will go into over the next few slides. But if we look at this graphic, you can think of items like day-to-day claiming, service documentation, following up on moments, and others between the LEAs and flowing to the lead LEA. For the connection from the lead billing consortium to DHCS, that is going to be items like their own compliance documents, such as the provider participation agreement, annual report, and data use agreement, random moment times study coordination, the RMTS coordination, day-to-day claiming, and the CRCS. Before I get into the details of the requirements, let me get into some of the benefits and why you might wait to join a consortium. So let's dive right into the benefits. Why might this model work for you either as a member LEA or a lead LEA? Having a lead billing consortium coordinator allows them the opportunity to develop specialized expertise to increase efficiency and effectiveness. What I mean by this really is the value of having a staff member with the ability to dedicate a large or larger part of their time to learning and mastering the details of the program and ensuring that compliance is being met. Having a group of LEAs to work with and brainstorm also fosters a really great, strong base of program knowledge. To that point, having the lead taking on a bigger role or bigger full-time employee FTE role can increase the efficiency by each consortium member not having to do every aspect of the program individually and reducing individual workload for the consortium member. For example, and of course this will vary by circumstances, but let's say you have the 6 LEAs that average 40% FTE each to run this program. With a consortium model, one LEA might have 100% FTE, and the other 5 may be able to reduce their time to 10 or 20%. You never want the consortium members to lose their individual expertise or knowledge and have that be 0, but there can be real savings in each LEA's staff time. So the specialized expertise and reduction in staff time leads me into my last point, which is maximizing the opportunity and benefits for small and/or rural LEAs. Each LEA will not need to know every small possible detail or billing opportunity, and nor will each LEA need to reinvent the wheel every year. Collectively, with a central lead, the time and energy can be optimized to support all billing opportunities. So just taking a quick look back at the graphic for the payment cycle we looked at earlier, we wanted to highlight some places where a billing consortium can ease administrative burden. As you can see, most of the boxes regarding the billing cycle have a little star. These are the areas where the billing consortium can assist. So box 1, LEA submits claims to DHCS for covered services. A lead billing consortium will work with their consortium members to submit claims to DHCS for covered services. Box 3, the LEA submits cost reports to certify costs. As mentioned earlier, the lead billing consortium would take charge of gathering cost information needed from member LEAs, as well as finalizing and submitting the cost report, or CRCS, to DHCS. And then box 4, DHCS audits to verify costs on the CRCS. A lead billing consortium would run point on any audits initiated and on the submitted cost reports. The only areas where the consortium would not really have a hand would be box 2 and box 5. Box 2 is DHCS sends interim reimbursements based on claims. This is a DHCS process to send back funds. And then for box 5, DHCS provides final settlement. And this is where DHCS confirms and provides final settlement amounts. In these cases, the consortium really does not play a role, but for all of those starred boxes, a consortium can be really extremely beneficial. In the graphic on this slide, you can see how the LEA interacts with the member LEAs. And now we will talk about the requirements. When we think of the graphic before about the lead billing consortia working with DHCS and the consortium members working together, this is what we mean. So one national provider identifier, NPI, is used for claiming, which is done by the lead LEA. One set of compliance documents, so that'd be one provider participation agreement, one annual report, one data use agreement for the entire consortium. Only one CRCS is submitted annually, and the consortium must contract for the RMTS with a local educational consortia, or LEC. It should also be noted that the program requirements, like documentation, are of course everyone's responsibility. That covers the major requirements, and now we're going to talk about the responsibilities of each group. So I'll pass it now back to Lydia to go over those individual responsibilities.
Thank you, Lacey. All right, so responsibilities on this slide show the responsibility specifically for a lead billing consortium, or the lead LEA. So the first thing that the lead LEA must do is, of course, enroll an LEA BOP. They will also be the point of contact between DHCS and the LEC. The lead LEA also submits those compliance documents we covered on the previous slides, the PPA, the data use agreement, the annual report, etc. They will submit all of these to DHCS. And this includes collecting letters from each participating member LEA regarding their understanding of the consortium involvement, and share that with DHCS along with the DUA. Excuse me. The lead consortia, or lead LEA, manages RMTS requirements. This includes contracting with the LEC for RMTS and ensuring that all member LEAs are participating in RMTS. And this can be a single contract or require multiple contracts with each consortium member. The structure depends upon your agreement between the consortium and the LEC. Whatever the agreed upon structure, it is important that all members are accounted for when it comes to program requirements, especially for RMTS. And a big takeaway is that communication between DHCS and the LEC is key to ensuring this compliance. The lead billing consortium submits claims for all members under the lead NPI number, and that is the NPI number that is attached to all interim claims sent to DHCS for the consortium. The lead billing consortium also maintains their own claiming and service documentation, and the lead consortium submits CRCS reports to DHCS, including gathering all consortium members' financial information, calculating the MER and indirect cost rate in accordance with the CRCS instructions, and distributing funds back to consortium members. This also means that audits are the responsibility of the lead billing consortium. It's their CRCS. They are expected to have all the necessary documentation needed. Now I would like to move on to specific responsibilities for consortium members. So the member LEAs will want to designate a point person for communication with the LEAD billing consortium for such things as the data use agreement requirements. Now, this includes for member LEAs. This includes submitting a letter from each participating member acknowledging that, 1, the LEAD LEA is its agent, 2, that the LEAD LEA is authorized to handle all matters concerning the LEA BOP with DHCS on behalf of the member LEA, 3, if the participating LEA is a Health Insurance Portability and Accessibility Act, HIPAA covered entity, and a HIPAA business associate agreement is in place with the LEAD LEA. 4, that letter also needs a confirmation that all personally identified data will be protected under FERPA and or, if applicable, HIPAA. And 5, last but not least, the LEAD LEA's authority is valid until the letter is replaced or revoked in writing by the participating LEA member. Now, this letter should be given to the LEAD Billing Consortium or LEAD LEA, who will in turn submit this letter to DHCS with the DUA. Now, consortium members are responsible for participating in RMTS and ensuring that all requirements are met. All staff that intends to bill and be part of the program need to be on the time survey participant list. Does it make sense for member LEAs to supply that list or have the LEAD LEA run HR reports and create the list? It could be a combination of both, but that's determined between the member and the LEAD LEA, and of course the LEC. And we also discussed managing your moments. Who do you want doing the follow-up with staff and staff that don't respond to moments in time? That is something you will want to coordinate with your LEAD billing consortium. And although the LEAD billing consortia can support with this process, it is the consortium members' responsibility to make sure they are complying with the requirements. As mentioned before, the staff time requirement should be less for consortium member, but it is still best practice to have a liaison. Now, consortium members also submitting in regard to submitting claims. Member LEAs need to provide their actual costs for delivering services to students, such as contracts or practitioner salary and benefits. They submit that to the LEAD LEA so that all consortium member costs are included on that one CRCS that the LEAD LEA turns into DHCS. The member LEA will make sure not to use their own MPI number to submit claims separately, or else it might come to a case of accidental double billing. Consortium members are also responsible for maintaining their own claiming and service documentation. All practitioners need to document services provided to students, but in a consortium, who is responsible for supporting service documentation? Does the LEAD LEA provide training to practitioners to all member LEAs? Or do all member LEAs use and access the same electronic health record system? The intricacies are up to the individual consortium in agreement with their LEC. And all these responsibilities should be clearly outlined in the MOU or cooperation agreement. Now, before we move on into the next section, here are some important clarifications regarding RMTS and the consortium. RMTS participation is a requirement for participating in the LEA BOP. The LEAD LEA needs to work with their LEC to determine how the RMTS contract will work. And this may vary or be handled differently depending upon which region. The LEAD LEA is responsible for RMTS compliance, including making sure the time survey participant or TSP lists are completed accurately and timely, and make sure moments are responded to. As a note, the quarterly time survey participant list must include the LEAD LEA and all member LEA practitioners, so that all practitioners are included on the RMTS and subject to random sampling. Once again, it is very important that all members are accounted for when it comes to RMTS compliance, and a clear communication between the consortium, DHCS, and the LEC is vital. Now we've all been talking at you for a few minutes now, and to break it up a little bit, we wanted to take a quick pause and mix it up with a few quiz questions. Don't worry, we won't be grading you. I'll open the poll and leave it open for a few minutes to allow for everyone to respond. And let me see if I can open it now. There we go. And I'll just launch it, and then we'll go over the questions, and after the fact, we will also go over all of the answers. So here we go. It should launch in the chat. If for some reason you have difficulty opening it, because sometimes Teams gets picky upon whether you entered the meeting via a web browser or if you went through the app, if you have any trouble accessing it, just feel free to either drop your answers in the chat or just keep tally of it on your own piece of paper. I will trust your responses. And here we go. So, question 1. What is a billing consortium? Is it an electronic health record system? Or B, a group of LEAs that bill under one NPI? C, a county office of education or SELPA that supports LEAs with their TSP list? D, I do not know. Question 2, what is not a requirement of a consortium member? Maintain claiming and service documentation would be A. B, participating in the RMTS. C, submitting compliance documents to DHCS. Or D, I don't know. Number 3, what is one requirement for a billing consortium? A, submit one CRCS for all participating LEAs. B, use the same billing vendor. C, redistribute the funds evenly. Or D, I do not know. And I'll leave it open just for a few minutes to give everybody a chance to respond. Let's see. Whoa, all right, there we go. I actually see them now. All right, I'm seeing a lot of responses for question 1 on B. A few scattered responses on question 2. 13% for A. And 3, okay, I see a lot of responses for question 3 also. Oh, 79% for A, nice. All right, I'll just give it one more minute for everybody to get a chance, and then we'll go over the responses. It looks like a few people are having difficulty with the chat feature. I'm sorry about that. That happens sometimes. Please feel free to drop your response in the chat or keep a tally of it yourself. Like I said, we'll be going over the answers here in just a few seconds. Oh, Shari, thank you. Marlene, thank you so much. All right. Anyone who still feels like adding in their responses, please feel free. I'm going to go ahead and get us started on the answers. It looks like a lot of people got these right already. So for question 1, the answer is B. It's a group of what is a billing consortium? It's a group of LEAs that bill under one NPI number. And they submit claims under that one NPI number and submit one CRCS, one annual report, one data use agreement, etc. And they all do so under that one NPI. So awesome job there. Question 2, What is not a requirement of a consortium member? Answer C, submitting the compliance documents to DHCS. As mentioned, compliance documents will be submitted to DHCS by the LEAD billing consortium. And member LEAs must, of course, provide the needed information, such as that letter for the DUA, but the responsibility of collecting these letters and filling out and submitting the DUA itself and any other such compliance documents is on the LEAD LEA. And last but not least, question 3. What is not a requirement for a billing consortium? The answer is A, submitting what is one requirement of a billing consortium, and the answer is A, submitting one CRCS for all participating LEA members. Like we mentioned before, it's the LEAD LEA's responsibility to submit those compliance documents forward, including the CRCS. And I will close out the, thank you, Sherry. I'll close out the quiz real quick and we will move on to our next section. And I am happy to hand it over to Debbie Connor from Mendocino COE to dig into a real world example of how consortium structure can look, as well as reinvestment of funds as a consortium. Thank you, everybody.
Thank you. Good morning. I wanted to talk a little bit about how our LEA BOP billing consortium makes considerations and helps LEAs to reinvest their reimbursements into activities that align with the ed code that we'll discuss here in a minute. So our LEA BOP consortium has been guided by careful considerations with a universal understanding that Medi-Cal reimbursements are critical to help offset the LEA's costs of providing medically necessary services to students in a school-based setting. Next slide. I'll detail how we make LEA BOP operational and reinvestment decisions developed from convening regular meetings that include the SELPA Policy Council bi-monthly public meetings that consist of our SELPA Executive Director, superintendents, community advisory members, and myself, the LEA BOP Administrator. We also host steering committee monthly public meetings that includes special education directors from each of our districts and charters, the SELPA Executive Director, the LEA BOP Administrator, a parent representative, and a community advisory member. As the lead LEA, it is our responsibility to submit the annual report and reinvestment considerations to DHCS. Utilizing decisions made within these collaborative meetings, the LEA BOP Administrator can complete the annual report and statement of commitment to reinvest on behalf of all consortium members. Our team provides ongoing technical support to partner LEAs to ensure the proper reinvestment of funds. This billing consortium does not make decisions specific to any one LEA's use of funds, but we regularly work with all LEAs to align their use of the funds to comply with Ed Code 8804 Section G, as is listed in part on the annual report form that is published by DHCS and completed by the lead LEA. Next slide. To develop a consortium, we carefully considered each LEA's staffing needs, and we recognized that LEAs were unable to staff personnel to individually coordinate the local education agency billing option program. We recognized that existing LEA administrative staff did not have the capacity to take on the additional responsibilities of operating an individual LEA BOP. We looked at the annual compliance documentation and looked how it can be consolidated to the lead LEA, which allows LEA members to not duplicate the efforts that are already being managed by the lead LEA. We looked at decreasing the costs associated with staffing to administer this program, so the reimbursements for services are able to be committed to the reinvestment of services directly related to student needs, not administrative personnel costs in our Consortium. All service providers receive focused technical assistance from the lead LEA and from our third-party billing vendor. We also looked at cost consolidation. The lead LEA can allocate the necessary staff time to serve all consortium members. Staff costs are shared to all member LEAs as a flat rate divided by each LEA's interim reimbursement, reflecting a reduced cost to each LEA. Lead LEA holds the contract for one third-party billing vendor, and those costs are also divided by each LEA's interim reimbursements, allowing a share of costs by all member LEAs, which is much greater than what would be paid by individual LEAs. Variances in MER and indirect cost rates amongst our member LEAs are quite minimal, honestly, and compared to the cost savings of not individually funding a position to coordinate LEA BOP operations, the difference in MER or what the cost might be to fund a position to run LEA BOP is really substantial cost savings to the member LEAs. Next slide. This slide shows a sample of our Excel remittance advice detail that we receive from our third-party billing vendor. This is a document that we keep as the lead LEA, and it helps us to track incoming interim reimbursements. We're able to see which students' services were paid, who the provider was, the LEA name, the amount paid, and the provider type. It's very important to us as the lead LEA that our billing vendor provides provides the LEA name that the student is enrolled in so that we can properly distribute each LEA's reimbursement after each district has closed their fiscal year. On this screen, it also shows just a sample of our RAD spreadsheet, but at the end it shows that we received $839,000 in Medi-Cal reimbursements by interim claiming, and we'll show on the next slide how we distribute those funds and also allocate our costs to be the LEA back to those districts. Next slide. In this sample, this is just a quick reference to what we keep on an annual basis to distribute all of the earned interim reimbursements back out to our LEAs. So we can see the sample LEA number, right? That's our actual member LEAs in column A. In column B, we see the total amount of interim reimbursement received for services provided to those LEAs students in column B. The DHCS study fee is in column C. We're estimating it at 5% for future years. This DHCS fee is directly multiplied by the amount of reimbursement received by each LEA. So each LEA pays their fair share of that fee. In column D, we take our total lead LEA staff costs that are dedicated to LEA BOP and divide that number by the total reimbursements at the bottom of column B and multiply the result by the LEA totals in column B. So each LEA is sharing a percentage of the lead LEA staff costs. Let's see, we then have column E, which we use the same sort of calculation for our billing vendor costs. So in column E, we list our total billing vendor costs. We divide that back out so that each LEA shares a smaller cost of contracting with a third-party billing vendor than what they would if they contracted individually. This results in a net income to districts in column F. If we have prior year rate adjustments, we use the same calculation formula to pay the LEAs for their share of those additional reimbursements in column G. Overall, we can see that this program costs about 30% of our interim reimbursements for member LEAs. Next slide. The collaborative decisions for reinvestment. This is a big issue. Our reinvestment decisions are determined by members of SELPA, special education departments, superintendents, fiscal advisors, and community members. Each partner LEA determines how they individually use their earned reimbursements according to Ed Code 8804, Section G. The lead LEA provides technical support and documentation to validate the areas of investment that our prior collaborative meetings have determined to be beneficial to the students in the consortiums and communities that we serve. Our collaborative teams review emerging and continued student health needs, and we reinvest to enhance services to support improved mental and behavioral health service costs, EPSDT, speech language, occupational and physical therapies, trained healthcare aides, registered credentialed school nurses, health service assessments, and other supports to improve student outcomes. Expenditures of each member LEA are verified when the lead LEA completes the annual report, as well as when we are completing our bridging documentation to prepare for the CRCS submission. Next slide. Mendocino County's Student Health Billing Consortium philosophy. MCOE provides educational leadership, resources, and services to schools and districts to ensure a wide array of educational opportunities for all students. It is the intention of the Mendocino County Office of Education to assist LEAs to first serve the students. We then look at billing opportunities for health services that LEAs are already providing to their students. We develop and maintain billing systems that will capture these supports and services that are eligible for reimbursements from Medi-Cal as well as all other health insurers. We strive to maintain a sustainable cost recovery system and work to expand service billing opportunities as the need is evident. We recognize that emerging billing systems need to be approached with a growth mindset and strive to provide strong structures that will allow utilization of all billing systems at a level that helps to support the needs of our partner LEAs while improving student outcomes. Next slide. If anyone has any questions, please feel free to reach out to Hillary, Angela, or I, and we will be happy to provide information related to how our consortium system works. Thank you.
All right, thank you so much, Debbie. That was amazing. Now we're going to get to your questions. Your questions with Q&A. First, we will respond to questions we receive through the registration. If we have time, we will get into questions coming through the chat. Any LEA BOP consortia questions will be covered by either the provider relations team or Debbie. And just a reminder, we will not be covering questions regarding CYBHI consortia structure today, but any CYBHI consortia questions we will pass along to the appropriate person. We have been monitoring the chat and we'll try to respond to as many questions as we can, but please note if there are any questions that we do not have time to answer today, we will follow up via email. Now on to our first question submitted via registration, and that question was, how does the lead LEA decide to bill other districts for participating in the consortium? Is there a standard way to do this? And for that question, I will actually hand it back over to Debbie.
Okay, and I think this might go along with Scott's question in the chat as well about our flat rate versus a shared rate for LEA members. So for Mendocino County, it's really important to remember that each consortium should determine their costs and reimbursement methodologies within their own systems, as there's not a standard or universal method required. In Mendocino County, we share the DHCS fee, the lead LEA staff cost, and the third-party billing vendor cost, as shown on that prior slide, to all member LEAs. This results in each LEA sharing a percentage of the total cost to participate in this consortium. And as far as the lead LEA staff, and this is pertaining to Scott's question, we track our time basically with like a daily PAR form to determine what % of our time is dedicated just to the LEA BOP consortium work. And that way we're able to take the appropriate % of our FTE costs to build back to the member consortium program.
Perfect. Thank you, Debbie. Now for question 2. What is the primary role of the collaborative and how are funding decisions handled if there is a disagreement among members? Additionally, what types of expenditures are typically allowed under the reimbursement funding? And for that, I will also pass it back to Debbie.
So our consortium's role is to primarily reduce the administrative burden and cost to participate in LEA BOP. Our collaborative meetings outline the reinvestment opportunities that are aligned with that Ed Code 8804 Section G, and it allows for each LEA to make their own determinations on how to reinvest their reimbursements.
Thank you, Debbie. And last question for you, Debbie. Question 3. What systems or platforms do consortia typically use to manage data sharing, claiming, and documentation among multiple LEAs?
In Mendocino County, we do require that all of our member LEAs use the same third-party billing vendor that we've contracted with in order to capture documentation. But due to the individual needs of various consortium models, there really isn't a typical system to advise on. But for us, it was really important to contract with a third-party billing vendor capable of accessing and housing all service referrals, consents, services, and case notes so that all data sharing, claiming, and documentation complies with our tri-party data use agreement with DHCS.
Amazing. Thank you so much. All right, question 4, how can I find local existing consortiums to join? And you can actually start out by talking to your COEs and other LEAs in your area that may have similar needs, philosophies, goals towards supporting students' health needs and improving funding resources to continue delivering school-based services. But if you continue having difficulty finding a consortium or just want a little additional help, please feel free to reach out to DHCS at lea@dhcs.ca.gov. We will be happy to point you in the right direction. Question 5, our last one via registration. What makes a consortium a consortium? Meaning, is it a group of LEAs in which a single TIN and NPI is used for billing purposes? Having multiple locations within a charter school, does that make it a consortium? That does not make it a consortium, correct? And the answer is that's correct. A consortium consists of separate LEAs that are sharing the administrative burdens of the program and billing under one NPI number. Individual school sites do not qualify as an LEA as a consortium. And that is actually the end of our questions received via registration. It looks like we still have a few minutes. So I'm going to check the chat system to see if there's any questions left that we need to answer. It looked like a lot of them already got answered by Debbie in her presentation. And after the fact, I do see some questions regarding slide decks and recordings. So we'll get back to you on those questions. Absolutely. Other than that, team, are you seeing any questions that I'm not that we should address? All right. All right, I guess the only ones I'm seeing so far are slide deck and recording questions, which we will follow up on. If there's no other questions, then I will move on to our resources and closing. So here's our resources and closing. While we have shared with you the various resources that are specific to how you can start and participate in a billing consortium, there are also other resources to support your LEA as LEA in other aspects of administering LEA BOP. And we do encourage you to spend time on the LEA BOP website and reach out to DHCS for any questions you may have through the LEA inbox. And we also encourage you to sign up for technical assistance with us. I will drop a link to the technical assistance form here after we close up. Please feel free to take a copy, fill out as much detail as you can, send it our way, and we'll be happy to set up a meeting with you. Here's just some additional helpful resources if you want to peruse these later, some slides from an October training, a quick link to the LEC service regions, and enrolling in RMTS, that LEC service region again. Just helpful resources if you'd like to peruse those later. And last but not least, we want to thank you so much for participating in today's workshop. We hope you enjoyed it and learned something new today. And as always, your feedback is incredibly important and informs how we develop future trainings. So please be sure to take a moment to complete our feedback survey. You can either use the QR code or there should be a link in the slide deck that was provided, and I will also drop the link again in the chat here in a second so you can have easy access. Please let us know your thoughts, and thank you so much for joining us today.